Good morning, good afternoon, or good evening, depending on what time of day it is for you. I'm Gordon Guyatt, and today I'm going to be talking about how we should teach evidence-based medicine in the 21st century. In the next 10 minutes, I'm going to be telling you about what evidence-based medicine was like at the start, how it has evolved, and the implications in how it's evolved for evidence-based medicine teaching in the 21st century. In particular, I'm going to describe two challenges that we face in terms of optimal evidence-based medicine teaching. This is the first publication that introduced evidence-based medicine to the world. It was published in the American College of Physicians Journal Club in the March-April edition in 1991. First time the term appeared in the medical literature. And in that paper, we described a patient who had iron deficiency anemia or was suspected of having iron deficiency anemia, and how the clinicians could sort out whether that was or was not indeed the case. The start of evidence-based medicine was then in 1991. And to show you how long ago that was, here's what I looked like when that paper was published. So what was the initial focus when evidence-based medicine got started? It was to teach clinicians to use the medical literature. But in particular, it was thought that clinicians could read the method sections, understand the method sections, and then, having understood it, move on to the results. That meant a major emphasis on what we called at the time, Dave Sackett started the term, critical appraisal, which meant in particular knowing in randomized trials about concealment and blinding and loss to follow-up and intention to treat, and being able to read the methods of randomized trials to ascertain whether those things were done optimally. It did also include the results and the application. But when we were teaching, we spent most of our time on the issues of what we call the validity or subsequently risk of bias of the studies. I took over the residency program at McMaster University in internal medicine in 1990, and I spent 7 years in the program, and it was something of a laboratory for me for learning about the teaching of evidence-based medicine. And after 7 years of doing this, I was disillusioned. I was disillusioned in that it became clear that despite my efforts over 7 years running this program, I was not producing internal medicine practitioners who could and would, in a sophisticated way, read the methods of the papers that they were looking at. And thus, the question came to mind, should we really be focusing on critical appraisal? And in fact, I and some of my colleagues decided that probably we should not. And in the BMJ in the year 2000, we published a paper suggesting that not all clinicians need to appraise the evidence from scratch. In fact, most do not. They all need some skills, and I'll talk about in this talk what those skills were. So most clinicians will not have the skills for sophisticated critical appraisal, and we better focus elsewhere. So 20 years later, it still has the message still has not fully got through. We need evidence-based medicine teachers to accept the reality that most clinicians will seldom or ever do critical appraisal, but they still will be making decisions, obviously, as clinicians, and if they are good clinicians, they will be working with their patients in shared decision-making to come to those decisions. Currently, in research that we have done that I don't have time to show you, they cannot interpret the results to do their shared decision-making well. And that suggests that should be the focus of our teaching. And indeed, we believe that we need to get evidence-based medicine teachers to understand the implications of this. We need to get them to de-emphasize critical appraisal and to emphasize understanding the results. We will be successful when that teaching works so that clinicians understand the results considerably better than in general they do at present. So, a second challenge. Clinicians will be relying on clinical practice guidelines. Excuse me. Good guidelines will be informed by systematic reviews, and good systematic reviews will include a presentation of the quality of the evidence. Most good systematic reviews, as an advocate of the great approach, I would suggest all rigorous good systematic reviews will be using the great approach to evaluate the quality of the evidence. What is that great approach? In the great approach, the confidence or certainty or quality of the evidence is characterized in one of four categories: high, moderate, low, and very low quality evidence. Randomized trials begin as high quality or certainty of evidence, but they may not stay as high quality or certainty of the evidence. Indeed, if the trials in terms of their methods were unconcealed, unblinded, and lost large numbers of patients to follow up, there will be a high risk of bias. And if most or all of the trials that inform the question have those problems, we're going to rate down our certainty of evidence for risk of bias. If the results are inconsistent across studies and we can't explain it, and explain that inconsistency, we're going to be rating down. If the results are indirect, I practice as a hospital-based internist. Nowadays, many of my patients are over 90. I rely on randomized trials to guide my practice, but in my patients over 90, I have to be a little skeptical because very few such patients were included in the trials that inform my practice. Thus, the trials provide indirect evidence for my patients over 90. If the confidence intervals are wide as a result of small sample sizes, small numbers of events, we can have problems with imprecision. And even if everything else looks good, we can still have problems with publication bias. Thus, although randomized trials start as high quality evidence, if they have these problems, they may be rated down to moderate, low, or even very low quality or certainty evidence. Observational studies, on the other hand, start as low certainty evidence. They can be rated down to very low because of the problems I've been through, but occasionally they may be rated up to moderate or even large certainty evidence. So we don't have randomized trials of hip replacement, but we know that most patients do well and improve markedly. We don't have trials of insulin in diabetic ketoacidosis, but we know that insulin works very well in patients with diabetic ketoacidosis. And we don't have trials of epinephrine for anaphylactic shock, but know that it works well. Why in each of these instances? Because there's very large effects that act relatively quickly. Thus, on occasion, observational studies can yield high quality evidence. So that is the great approach, and clinicians need to understand not how to apply it themselves, but they understand and have an appreciation for what it means when they're told that the evidence is high, moderate, or very low quality or certainty. So clinicians will be relying on guidelines. Good guidelines will be informed by systematic reviews that present the quality of the evidence, ideally, and for what I would argue for rigorous guidelines, for rigorous systematic reviews that then inform trustworthy guidelines, they'll be using the great approach. We will then be successful when clinicians understand the quality or certainty of the evidence, and they understand what the great approach is all about and can communicate to their patients when the evidence is high, moderate, low, or very low quality or certainty. So to summarize the two key messages of this talk, clinicians will understand the results. When clinicians will understand the results, that will be when we determine success. When they teach guidelines, when they teach grade, when they teach results, not when they teach critical appraisal, because clinicians aren't going to be doing clinician critical appraisal. We will be successful when they understand guidelines and the systematic reviews that inform the guidelines. Those systematic reviews then presenting the quality of the evidence and ultimately the guidelines, strength of recommendations. Clinicians need to understand the quality of the evidence in those systematic reviews, and they need to understand strong and weak recommendations. Thanks very much. It's been a pleasure talking to you.